Hola, this is Dr. Stricker again. This is part 2 of my talk, Complexity of Lyme Disease Diagnosis and Treatment. In this part of the talk, I will discuss pathogenesis of Lyme disease, diagnosis, treatment, congenital and sexual transmission of the disease, and vaccine prospects. So in order to understand whether Lyme disease can be a chronic infection, you have to understand the pathophysiology of Lyme disease. And I'm convinced that eventually we will all dress like this person. So the characteristics of Borrelia burgdorferi, the Lyme bacteria, it has over 1,500 gene sequences and at least 132 functioning genes. And in contrast, the Treponema pallidum, the agent of syphilis, has only 22 functioning genes. As many as 22 plasmids are in the Lyme bacteria, and this is 3 times more than any known bacteria. And the Lyme spirochete engages in stealth pathology, which evades the immune response. Now, the makeup of the Borrelia genome is quite unusual. It consists of a linear chromosome and then a number of circular and linear plasmids that contain genetic material. To show this another way, the Borrelia chromosome has 860 genes, whereas the plasmids have 708 genes. Not all of these are functional genes, but a number of them are significant. And basically, this makeup is so unusual that Borrelia species have been called the most unusual genome on the planet. Now, the genotypes of Borrelia based on the OSPC genotype, which is one part of the spirochete, differ from the East Coast versus the West Coast. So on the East Coast, there are 4 genotypes, KABI, that are the most common. And if you look at K, there's 31% of those bacteria have that genotype. In contrast, on the West Coast, if you look for K, it's not to be found over here. A is there, but it's only 10% of the genotypes present. And then there are all these other variations. So there's a lot of genetic variability in the spirochete from one end of the country to the other. And this indicates that it may be very difficult to treat this infection with all these different genotypes. Now, in terms of stealth pathology, there are 4 parts to this: immune suppression, phase and antigenic variation, physical seclusion in both intracellular and extracellular sites, and then secreted factors. And these all help the Lyme spirochete to evade the immune response. And just to show you this in cartoon fashion, the main features of stealth pathology are downregulation of the outer surface proteins, hiding in extracellular matrix, so the bacteria can't be seen, and then immune suppression with complement inhibitory proteins that block the effect of the immune system. And just to show you this last part, Borrelia has these, on the outer surface membrane, has these binding proteins that bind parts of complement, which can normally kill bacteria, but because of these binding proteins, they neutralize the complement, and that allows the Lyme spirochete to persist and evade the effect of the immune system and destruction by the immune system. Other features of the Lyme spirochete, this is work by David Dorward at Rocky Mountain Lab, showing that the Lyme spirochete can actually traverse human immune cells, lymphocytes. We don't really know what happens when the bacteria do this, but it's a kind of peculiar process, and it may make the lymphocytes less reactive to the bacteria when they do this kind of invasion of lymphocytes. In addition, the effect of tick saliva is significant in terms of suppressing the immune response. So when a tick bites you, it secretes all these salivary proteins that can suppress the immune system and allow the spirochete to persist. And once Borrelia does get into the body, there are various effects on different aspects of metabolism. There's an effect on carbohydrate metabolism, phospholipid metabolism, and fatty acid metabolism. And this allows the Lyme spirochete to persist and to thrive within the host cells. So all in all, this is a pretty nasty bug. And in addition to all that, there are two other aspects of infection with the Lyme spirochete that are significant in terms of cysts and biofilms. Cysts are cell wall deficient forms of bacteria, and there is a problem with confusion over the terminology for these cell wall deficient forms. For coccobacillary organisms, cysts are called spheroplasts or L forms, but for spirochetes, they're called cysts or round bodies, but these terms have been used interchangeably and have caused some confusion. Cell wall deficient forms of Borrelia were first described in 1993 by Margulis and colleagues. In 1996, Priyak Mersic demonstrated in vitro cultivation of these cyst forms. And in 1997, the Brorsons demonstrated reversion of the Borrelia cyst forms to spirochetal morphology. So these cyst forms can persist and can evade the immune response. These are pictures of round bodies or cysts, which are these cell wall deficient bacteria within this outer membrane that protects them. And the Borrelia can live quite happily in this form for some time, being immune from the immune response. And this is a study done by Eva Shappi some years ago showing the effect of antibiotics on the spirochetes. So starting out with the control, there are equal numbers of spirochetes and round bodies or cysts. With the addition of doxycycline, antibiotic, you see that the spirochete numbers go down, if you look at the blue, to virtually zero, whereas the cyst forms increase significantly. So antibiotic treatment will promote development of these cyst forms if they are not specifically treated. Another aspect of persistence is the biofilm, and shown here. And biofilms are basically bacteria covered with slime. The slime is made up of things like sialomucin and hyaluronic acid, and it can cover the bacteria and protect it against the immune system and against antibiotics. And that is shown on this slide. Now, biofilms generally need a surface to propagate. And it was thought that unless you had a catheter or some external surface that this wouldn't happen. But now we know that biofilms can actually occur in almost any tissue or organ. And this is a mechanism by which the Lyme bacteria can evade the immune system and also evade antibiotics. And furthermore, there are other forms of the Lyme bacteria that are called antibiotic tolerant persisters. And these are not organisms that are resistant to antibiotics, but they tolerate the antibiotics. So they can survive while the antibiotics are there. And once the antibiotics are removed, they come back to life and can resume growth. So this is another reason why short-term antibiotic therapy may not be effective in Lyme disease because of Lyme persisters. So now we come to testing, laboratory testing for Lyme disease. You've heard about this from Dr. Shah. The classic two-tier testing for Lyme is shown on this slide. And this involves a first screening test with an enzyme immunoassay or immunofluorescence assay. If that test is positive or equivocal, then you go to a confirmatory Western blot. And the problem with this system is that if the screening test is negative, then you're not going to get diagnosed Lyme disease. And this is a problem if the screening test is not all that sensitive. Now, theoretically, the screening test, ELISA or IFA, is very sensitive. but it's based on a laboratory strain of Borrelia that doesn't exist in nature. And also there's large variation in commercial test quality. So it may not be as sensitive as we're told. The Western blot is more specific in theory, but the criteria for a positive test are very stringent. And there's large variation in laboratory proficiency with the Western blot. In addition, men and women react differently on the Western blot. I don't have time to go into that, but that may be a problem as well. So now, when you look at two-tier testing in the US, and these were tests done with patient controls, which is important, the specificity of two-tier testing is fantastic, 99% specificity, which means there are very few false positives. However, the sensitivity of two-tier testing is terrible, 46%. It misses more than half of Lyme disease cases. And so these are numbers that are inadequate for a diagnostic test if they miss more than half of the cases. And to put this in perspective, our AIDS testing has a sensitivity of 99.68%. So would an AIDS test with 46% sensitivity be satisfactory? And I think the answer to that is absolutely not. And so that's in the US. What about in Europe? Things must be better there, right? Well, no, not really. This is a study done more than 20 years ago looking at two-tier testing in Europe. And for early Lyme borreliosis and late Lyme borreliosis, they found, again, sensitivity of 30 to 40%, maybe as high as 50% for early disease. And then in the 30s and 40s for late Lyme disease. So again, inadequate test results for a diagnostic test. Now, this was over 20 years ago. Have things gotten any better? Well, the answer is not really. This is a study from 2011. And again, with the screening tests, you have a sensitivity of 46%. So you're going to miss more than half of Lyme cases if you're using this two-tier system. And it doesn't really matter what the sensitivity of the confirmatory test is if you never get to the confirmatory test because your screening test is so insensitive. So the two-tier test system has caused a lot of problems for Lyme diagnosis. There have been attempts to improve the sensitivity using the C6 peptide, which is a Lyme spirochete peptide that may give more sensitivity. But in fact, when you look at these tests using the C6 peptide, the average sensitivity is only 69%, which is still not really good enough for a diagnostic test. So how can we improve on the commercial Western blot? And if you've already heard about this from Dr. Shah, then this is just a brief summary. IGeneX has developed a method to do this type of testing that involves two significant modifications. One is that they use a double strain of the Lyme bacteria, not just the single strain that's used in the commercial tests. And the second modification is the interpretation of the Western blot using only 2 bands as opposed to the 5 to 10 bands that were used in the commercial test. And comparing the IGeneX system to a commercial system, one of the commercial systems shown here, if you look at testing with this commercial system, maximum sensitivity is 77%. If you only look at the IgG, which you're supposed to do if it's chronic Lyme, only 49% sensitivity, so similar to the tests that I showed you before. In contrast, if you look at the IGeneX system, you get a 97% sensitivity using their modification. So which one is better, 49%, 97%? I don't think it's a very difficult decision to make. So Lyme testing, and I'm sure you'll hear more from Dr. Shah about this. IGeneX has improved their technique using the immunoblot techniques, which you'll hear more about, which also has similar sensitivity and has proved very good for diagnostic testing for Lyme disease. Now, there are some companion tests that are useful in evaluating patients with Lyme disease, and 2 of them are shown on this slide. The CD57 natural killer cell subset is useful for monitoring patients with the disease, and it's readily available, so it's easy to do. C4a testing is an inflammatory marker that correlates with symptoms. And that's also been somewhat useful to see whether Lyme disease is very active, to look at the activity of the Lyme disease. Now, the CD57 natural killer cell marker is found on these wild natural killer cells. It is a subset of natural killer cells that's distinct from the CD56 natural killer cells, which is the major natural killer cell subset. So you have to be very careful when you talk to your laboratory and you say, I want to do this CD57 natural killer cell test, and they say, oh, we can measure natural killer cells. And then the next thing you know, you get back the CD56 subset, which is the wrong subset. So you have to be very specific about doing CD57 natural killer cells. The function of these cells is poorly understood. They are downregulated by certain cytokines, interleukin-2, interferon, and tumor necrosis factor. And the CD57 marker is also found on other cells, including T cells and nerve cells, which is kind of interesting, but we don't really know very much about these cells. Now, a number of years ago, Ed Winger and I did a study looking at patients with chronic Lyme disease, actually at various stages of Lyme disease. And what we found was that patients with acute Lyme disease had normal levels of these cells, but when we looked at Lyme disease pre-treatment, the level of these cells was significantly lower. On treatment, the level of the cells increased, and then post-treatment, when patients had recovered, the level of the cells went up to a very good level. In contrast, when we looked at AIDS patients who have very few T cells, interestingly, they maintain their natural killer cells as shown here, or at least their CD57 natural killer cells. So there's a significant difference between the Lyme patients and even the AIDS patients. So this was a useful marker for untreated Lyme disease. And again, you can follow it with treatment. The level of the cell should get better with treatment. And another way to look at this is an old slide, but CD57 natural killer cells are kind of the CD4 T cells of chronic Lyme disease. You know, CD4 T cells was how we measured AIDS in the old days before we had molecular techniques. And so this is a way of looking at chronic Lyme disease based on these cell numbers. Now, complement activation is also part of the Lyme process. Complement activation is rather complicated, but if you look at the C4A marker, it's in here somewhere. And this is a marker of activation based on the infection. Now, Richie Shoemaker's group did a study in acute Lyme disease patients and showed that C4A levels were increased in these patients significantly over controls. So we were interested in looking at patients with chronic Lyme disease to see if we had the same changes. And in fact, we did find something similar. Here's control patients who had normal levels of C4A. In Lyme patients with musculoskeletal disease, we had significant increases in the C4A. Patients with neurologic Lyme disease had increased levels, but less so than the musculoskeletal patients. And then interestingly, in patients with systemic lupus and AIDS, they also had significant increases in their C4A levels. So this is by no means a specific test for Lyme disease, but it is a useful test to look at inflammation, especially in patients who have primarily musculoskeletal Lyme disease. Now, other markers of chronic Lyme disease have been suggested, mainly cytokines. And the distribution of these cytokines is shown on this slide. This is a study from Johns Hopkins University. Cytokines are potentially good markers of this disease, but the problem with cytokines is that they have very short half-lives. So measuring them is really a challenge. And so until we get a better system to measure these cytokines, they're really not as useful as something like the CD57 natural killer cells, which is a more stable marker, and also the C4A levels. A number of years ago, Eva Shapi did some studies looking at cultures of Borrelia and found that she could actually culture Borrelia in the special medium within a week for about half of patients with Lyme infection. There was a company that tried to commercialize this testing, and unfortunately, they failed they went out of business. Doing these cultures, you can see the spirochetes with immunofluorescent testing. But again, this test does not exist anymore because the company that was doing it went out of business. So now we come to treatment of Lyme disease. And treatment of Lyme disease really revolves around failure of treatment for Lyme disease, which was reported back in 1989 by Priyak Mursik's group. This group found that they could culture Borrelia out of patients after antibiotic therapy, even if their antibody response was decreased. And this led to a controversy over persistent infection with Lyme disease. And as you can see from the statement from the New York Times, there's no credible scientific evidence for the persistence of symptomatic Borrelia burgdorferi infection after antibiotic treatment. So we went looking for credible scientific evidence of persistent infection, and PubMed lists over 40,000 articles about tick-borne diseases as of this month. And there are a number of animal models of chronic Lyme disease. So first we looked at that. In rodents, there are a number of studies that show persistent infection in gerbils, in hamsters, in mice, in more mice, and more mice, and more mice. So there are a number of studies showing persistent infection in rodents. What about dogs? Well, there are some animal models of dogs with persistent infection. In one study, the dogs had a positive culture results over a 500-day post-infection period, which is the equivalent of 4 to 7 years in humans for persistent infection. What about monkeys? Non-human primates have shown persistent infection as well. The work of Monica Embers in particular has shown persistent infection in non-human primates after inadequate treatment for Lyme disease. And then in horses, there's a horse model of Lyme infection from Cornell that has shown persistent infection in these animals. So in summary, you have persistent Lyme disease in gerbils, hamsters, mice, dogs, monkeys, and horses, but not humans. So can that be? Well, in fact, it can't be. There are a number of studies of human infection with the Lyme spirochete that show persistent infection by different techniques. Many are from Europe, some are from the US, as shown on this slide. This is actually an old slide, so there are even more studies since this one. And here are some highlights from these studies. I'm not going to have time to go through them, but the one I liked the best was from Priyak Mursik, where Borrelia was cultured from an iris biopsy of a patient who had visual changes. And then there are other studies showing persistent infection by different techniques. And this reflects a much older study from 1989 by Joe Burrascano, who looked at a bunch of Lyme patients with short course treatment, less than 60 days of antibiotic treatment. And what he found was that the number of successful outcomes in this patient was extremely low, with doxycycline, penicillin, amoxicillin, and even intravenous ceftriaxone. Maximum success was 13.9%. And in three of these patient groups, there was 0 successful treatment. So again, short course antibiotics don't seem to work very well against Lyme disease in these patients. Now, does longer antibiotic treatment help in persistent Lyme disease? Well, there are a number of studies that suggest that that may be the case. This is a study from Finland looking at 4 to 6 weeks of treatment with better outcome with IV antibiotics, ceftriaxone. The studies by Dr. Donta were actually the most compelling, showing longer treatment may be more successful. And to summarize this, when he used antibiotics for 2 months, the symptom improvement was 33%. When he used antibiotics for 3 months, he had a 61% improvement. So And this is with tetracycline therapy, which wasn't all that aggressive. So again, longer treatment for Lyme disease seems to be more successful. And then we come to the controlled studies of persistent Lyme disease, as shown on these slides. The Krupp study looked at fatigue and found that patients did significantly better than controls in terms of fatigue improvement with study for 4 weeks versus placebo. The Klempner trials have been cited the most often as proof that long-term antibiotics don't work. These patients got 4 weeks of IV ceftriaxone and then doxycycline for 2 months. And this study was criticized because subjects had been sick for an average of 4.7 years and had already failed similar treatment. So this was really a study that was stacked against the treatment regimen. And then Dan Cameron did a study of oral amoxicillin for 3 months. And these were in patients who had only been sick an average of 7 months, and found that he had success in about 2/3 of his patients who had a fairly good quality of life. And then the study by Brian Fallon looking at IV ceftriaxone for 10 weeks showed significant improvement in these patients, even though they had been sick for an average of 9 years. But the problem is when the treatment was stopped, they had cognitive relapse, which was significant. So again, some evidence that longer treatment works, but then it stops working when you stop the treatment. And again, this is showing the fatigue levels in the studies by Krupp and Fallon. And with the ceftriaxone, you had significant improvement in fatigue in these patients with longer treatment. Now, the latest incarnation of these trials is the PLEASE study by Verende and colleagues, which is kind of an interesting study because they did a 12-week course of treatment with initially 2 weeks of ceftriaxone for all groups. So they didn't really have a control group because everybody got antibiotics for 2 weeks. And then they split them up into doxycycline, clarithromycin plus hydroxychloroquine, or no treatment. And what they found was that, first of all, these patients were severely impaired. This is the average in the general population for physical component score. 50 is the average. These patients started out at 30, less than 35, so that's severely impaired. They all got 2 weeks of ceftriaxone, and that made them better. And then the treatment went to 12 weeks, and then they were followed up for a year. And there was no further improvement after that initial 12-week period. So based on this, the statement was that there really wasn't any improvement, but in fact, there was some improvement in these severely impaired individuals. And again, it begs the question, what if you continue the treatment beyond 12 weeks? Would this continue to improve up to something closer to the general population? So again, this study leaves a lot of questions and doesn't show that longer antibiotic therapy doesn't work, which it's been interpreted as by some people. So why are we so afraid of antibiotics? Well, long-term antibiotic therapy may be dangerous, leading to potentially fatal infections in the bloodstream as a result of this treatment. But in fact, there are a number of treatments where long-term antibiotics are accepted and actually the standard of care. And some of these infections are shown on this slide. With lengths of treatment between 6 months up to my favorite 5.7 years for alveolar echinococcosis. Even with 5.7 years of treatment, a lot of those patients relapsed. So long-term treatment for these diseases is accepted and pretty much standard of care, and there's no big concern about patients dying with these treatments. So what's so different about Lyme disease? The answer is, who knows? Now, the principles of antibiotic therapy for Lyme, we use oral antibiotics for musculoskeletal disease and intravenous antibiotics for neurologic disease, and prolonged treatment may be necessary, and we rotate these therapies to get the optimal benefit. For treatment options, for oral antibiotics, there's monotherapy and combination therapy. For intravenous antibiotics, there's either daily or staggered therapy. And then there's also intramuscular therapy, which isn't all that much fun for patients. In terms of monotherapy, doxycycline and minocycline have good tissue penetration and cover Borrelia and Ehrlichia. It also has anti-inflammatory properties, but the main side effects are photosensitivity and GI upset. For amoxicillin or Augmentin, it's less effective, but has less side effects than the tetracyclines. And then there are combination antibiotics with basically a macrolide plus amoxicillin or cephalosporin or a nitroimidazole. And these have been sort of the backbone of treatment for chronic Lyme with musculoskeletal symptoms. For intravenous antibiotics, ceftriaxone is still the drug of choice. It can be given once daily. It has good central nervous system penetration. Does cause liver toxicity, so you have to monitor liver functions when you're doing it. The other options, cefotaxime, doxycycline, and azithromycin, have less evidence that they work as well, and they do have side effects. Now, when you're doing this treatment, you have to watch out for a Herxheimer reaction. A Herxheimer reaction is a die-off of the bacteria. And when the bacteria die, they release all these toxins and cytokines, and symptoms may actually get worse, which is a good sign because it shows that the treatment is working. So you'd actually like to look for a Herxheimer reaction as a sign that you may be on the right track in treating this infection. So now, what about safety of intravenous antibiotic therapy for chronic Lyme disease? So we did a study a number of years ago of 200 patients with neurologic Lyme disease. And the mean length of intravenous antibiotic treatment was 118 days, so almost 4 months, representing over 23,000 intravascular device days. So almost 10 times more days with these catheters than in previous studies. The findings in this study were that 7 patients, or 3.5%, experienced allergic reactions, and 2 patients had gallbladder toxicity during the study, 1%. Complications from the intravascular device were seen in 15 patients, or 7.5% of patients. None of these complications were fatal. And when we compared the results of this study to previous studies that I mentioned, again, 4 months of treatment versus the longest here was a little over 2 months, 10 times the number of days with intravenous catheters, and the complication rate that you see here was similar or less than other shorter studies. So doesn't look like there's a big problem in terms of safety using intravenous catheters for treatment of chronic Lyme disease. Now, what about the benefit of intravenous antibiotic therapy in chronic Lyme disease? Well, what we did was we separated the patients into categories based on the length of treatment. So patients who were treated 1 to 4 weeks, 5 to 8 weeks, 9 to 12 weeks, 13 to 24 weeks, and also patients who were treated for 6 months to a year with intravenous therapy. And for endpoints, we looked at fatigue, cognition, myalgias, and arthralgias. And these were established a priori before doing the study. What we found, and just to make long story short, if you look at cognition, which was the major endpoint for these patients, it took 6 to 12 months of treatment to get improvement in cognition in this group of patients. So what this means is that treatment for 6 to 12 months may be necessary to obtain significant symptomatic improvement in patients with neurologic Lyme disease. And this is, again, a topic that's still controversial. There's still people who think that 2 weeks of antibiotics can cure everybody. But based on this study in patients with neurologic disease, it looks like much longer treatment is necessary to get these patients better. Now, why does it take so long to do this treatment? Well, the drugs that we're using are 50 to 60 years old. They're not very effective. Over the past few years, we've seen some designer drugs developed for other diseases, such as HIV/AIDS and hepatitis C. These drugs are based on inhibition of the proteases of these viruses. And more recently, we've seen medications developed for SARS-CoV-2, which are also based on protease inhibition of the viral proteases. So why can't we develop the same thing for Lyme disease, for Borrelia? Well, the answer is we probably could. There's plenty of proteases that play a role in Lyme disease. We just have to have the will to develop these drugs and to test them and to see if they work. Hopefully someday that will happen. Unfortunately, it hasn't happened yet. Other aspects of treating with antibiotics, it's important to use probiotics when you're doing antibiotic treatment to avoid problems with the gut. This is a chart that shows different types of probiotics. Saccharomyces is probably the best in terms of counteracting all antibiotics, whereas other acidophilus-based probiotics may be useful, and combinations of probiotics may also be useful, but you have to be careful because the acidophilus-based probiotics can interfere with antibiotic treatment, whereas Saccharomyces does not do that. So it can be actually taken with the antibiotics, which is a benefit. And then supplements and alternative treatments. There's an awful lot in this area. Alternative and complementary treatments for Lyme disease. With some exceptions, there's not much evidence that they work. There are conflicting therapeutic theories, such as oxygen radicals versus antioxidants. There's no regulation of these products, and they are expensive. So there are compounds like milk thistle, which actually have been shown to reduce liver inflammation and which are useful if you have some liver toxicity from your treatment. But aside from that, it's unclear whether these alternative treatments are really effective. Something like the Rife machine has been promoted to treat Lyme disease, but again, that's another area that is uncertain. And just to give you some idea of where we are with Lyme disease, this was the standard treatment for HIV disease in 1999. It was basically vitamin A, vitamin B, and vitamin E and C. Azithromycin had just, AZT had just come on the market, and they weren't sure if that was going to work. So right now with Lyme, we're kind of in this stage with vitamins, and it would be nice to have some better medications to treat this disease. And as you can see for AIDS, this is what happened. We had this explosion of antiviral drugs that led to the miracle cures for HIV. And again, hopefully this will happen for Lyme. Now, what about congenital Lyme? Well, congenital Lyme is controversial. For a long time, it was thought that Lyme could not be transmitted during pregnancy. However, it was clear that other forms of Borrelia were transmitted during pregnancy, especially the relapsing fever spirochetes found in Africa. And this transmission could be fatal. As you can see here, many of these infants died after infection in utero. Borrelia hermsii, again, the most common tick-borne relapsing fever in the US, can cause infection during pregnancy. Here you see a blood smear from a newborn that has tons of these spirochetes all over the place from infection during pregnancy. There's a mouse model of this. This is a mouse infected with Borrelia duttoni in utero, and you can see that the mouse fetus isn't doing so well over here, and is actually, this is a fatal infection. So there is evidence that Borrelia can be transmitted during pregnancy. This is from relapsing fever in the mouse, and you have organisms in the placenta. And what about congenital Lyme disease? Well, this was a study done fairly recently, and 61% of pregnancies in patients with Lyme disease had health issues, and only 39% ended up with healthy babies. So Lyme disease during pregnancy is a bad disease and needs to be addressed. Generally, we give antibiotic therapy during pregnancy to women who have Lyme disease. and this prevents transmission of the disease during pregnancy. What about children born with Lyme disease? This is from the work of Charles Ray Jones. A lot of symptoms associated with the Lyme bacteria and the Lyme infection in these children, and congenital transmission. So again, the goal is to avoid that transmission by doing treatment during pregnancy to prevent transmission. Now, what about one other interesting aspect? What about transmission of Lyme disease by intimate human contact? And it's not necessarily sexual transmission. It can be just intimate contact. There are animal models for this in mice and dogs, and also in ticks. Interestingly, ticks have sex and they can transmit Lyme during tick sex. So there are definitely models of this. Now, the problem is there are also some other animal models like Lewis rats and Syrian hamsters that do not transmit Lyme during sex. So it's, again, somewhat controversial how this happens or how often this happens. We did a study in humans looking at genital secretions, and by various techniques, we found that Borrelia was present in these secretions, and it was the same species in both partners. Interestingly, in one couple, they both had a different species of Borrelia. They had Borrelia hermsii in their genital secretions. So again, this is circumstantial evidence that Borrelia can be shared by intimate contact. And this is to show you what Borrelia spirochetes look like on the left next to a sperm cell in a semen sample. So these two things can be present. And we need to do a lot more work on sexual transmission. Again, with the animal models, it's hard to pick a good model, but certain groups are doing that. Now, what about a vaccine for Lyme disease? The interesting thing is I showed this a few years ago to a group of young interns, and half of them didn't know who the guy in the middle was, but I guess now everybody knows because we had this new movie about Elvis. We did have a vaccine for Lyme disease back in 2001. The vaccine was taken off the market because of a class action lawsuit by a number of patients who had negative reactions to the vaccine and developed something that looked like Lyme disease from the vaccine. We now have a new Lyme vaccine that's being developed that's very similar to this old one, and we'll see how that goes. I'm not very positive about the future for that. Lyme vaccine targets have been discussed, and there's a number of possibilities. The Lyme vaccine just targeting OspA, which is the Borrelia protein, would only affect Lyme bacteria. It would not affect other co-infecting organisms. So that is a drawback of doing this type of specific Lyme vaccine. But there are other targets that are derived from tick proteins, tick saliva proteins, that could be much better targets for the vaccine, because that would prevent transmission not just of the Lyme bacteria, but other co-infections. And so some of these proteins are shown on this slide. One problem with these proteins is that they're not very immunogenic, so they're not really that great a target for a vaccine, but there are ways to manipulate them. And I think at some point we will end up with a vaccine based on these tick saliva proteins. And again, and another problem is that during tick feeding, some of these proteins are upregulated, but some are downregulated. So you don't want to target a downregulated protein. You want something that's upregulated during tick feeding, something here. And again, this is an area where we're going to see a lot of developments in the coming years. So in conclusion, Lyme disease and co-infections are spreading. Borrelia burgdorferi is difficult to eradicate. Lyme testing is not as sensitive as we were told. Lyme treatment failure is more common than we think, and prolonged antibiotic therapy appears to be relatively safe and clinically beneficial in persistent Lyme disease. And I'd like to thank the many people involved with Lyme disease research and clinical work, especially, of course, IGeneX Laboratory, LymeDisease.org, and the Lyme Disease Association, the researchers and clinicians who've contributed to Lyme work, and the University of New Haven with Ava Shoppe. And then I'd also like to acknowledge the Lindorf Family Foundation and the Peterson Family Foundation for their generous support of our work. And if you want more information about tick-borne diseases, please visit the Union Square Medical Associates website at www.usmamed.com. Thank you very much for your attention.